Consider two patients in the intensive care unit meeting the exact same diagnostic criteria for acute respiratory distress syndrome. Both present with a PaO2 to FiO2 ratio of 120, a PEEP of 10, and a static compliance of exactly 30. Standard bedside metrics suggest these patients have identical injury severity, but these global numbers provide no insight into the spatial arrangement of that damage, leaving the clinician blind to the actual mechanics of the lung. These CT scans reveal the morphological reality. The left patient has focal dorsal consolidation. The right exhibits diffuse ground glass opacities. Applying uniform high PEEP yields starkly different results. Pressure rescues the diffuse phenotype by reopening alveoli, but induces lethal overdistension in the focal phenotype. Global oxygenation metrics and standard compliance measurements obscure the actual morphology of the injury. Delivering individualized protective care requires regional imaging to map the damage. To understand why these patterns form, we have to examine the physical forces inside an edematous lung. As extravascular water accumulates, the pulmonary tissue becomes heavy, generating a gravity-dependent pressure gradient from the ventral surface to the dorsal base. This weight creates superimposed pressure. When this localized hydrostatic load exceeds the air pressure inside the airways, the dependent alveoli are crushed and collapse. This collapse drastically reduces the volume of functional aerated tissue. The remaining inflatable space, often called the baby lung, is not intrinsically stiff, but its total volume is a fraction of a healthy organ. When a standard tidal volume, calculated from the patient's predicted body weight, is forced into this small fraction of aerated tissue, the regional stress and strain multiply, actively destroying the remaining healthy tissue. The baby lung is a dynamic functional state that shifts with positioning and pressure. Mapping its distribution dynamically is the only way to titrate protective ventilation to the exact size of the usable lung. Thoracic CT allows clinicians to classify aeration loss along a spectrum, ranging from strictly focal disease with ventral sparing to diffuse lung-wide consolidation. Relying on subjective visual assessment to classify these states is prone to error. The live trial demonstrated that misclassifying these patterns and applying the wrong ventilation strategy actively worsens patient survival, necessitating strict quantitative metrics. This chart shows the focal index, a numerical measure of the ventrodorsal injury gradient based on Hounsfield unit histograms. A complete overlap of regional curves yields a score near 0, indicating a diffuse pattern, while wide separation of curves indicates highly focal injury. This structural index correlates directly with underlying biology. Diffuse patterns typically present with higher circulating levels of S-RAGE, a biomarker released by injured type 1 alveolar cells, indicating severe epithelial destruction and a higher risk of mortality. By quantifying the spatial distribution of aeration, the focal index provides a reproducible physiological anchor for morphological subphenotyping. Even with precise static measurements, tracking how these lungs respond to applied pressure reveals the recruitability paradox. Global compliance improvements do not distinguish between the true recruitment of collapsed tissue and the dangerous hyperinflation of units that are already open. This workflow for elastic image registration aligns end expiration and end inspiration CT scans to track precise voxel density changes. The resulting Jacobian determinant map visualizes regional volumetric expansion, isolating tissue stretch. Finally, parametric response mapping highlights unstable inflation, tissue undergoing cyclic collapse, driving secondary lung injury. When the fraction of this unstable tissue exceeds 28%, it becomes a powerful independent predictor of mortality in ARDS cohorts. Dynamic CT registration replaces blind estimates of potential recruitability with direct visualization of regional tissue strain as it happens. Gas exchange failure often originates within the pulmonary vasculature. Endothelial injury and widespread microthrombosis disrupt blood flow, creating physiological shunts that mechanical ventilation alone cannot resolve. Dual energy CT uses energy-dependent attenuation during a single contrast-enhanced scan to separate iodine from background tissue, generating maps of perfused blood volume. These maps contrast inflation on the left with iodine-based perfusion on the right. The yellow arrow identifies a shunt, a region of hyperperfusion in non-aerated tissue. The white arrow points to a perfusion defect within a ground glass region, a form of dead space. Patients exhibiting high D-dimer concentrations and elevated ventilatory ratios frequently demonstrate this diffuse hypoperfusion across their scans, linking circulating coagulation markers directly to vascular failure. By identifying this vasocentric hypoxemia, dual-energy CT explains why specific patients remain profoundly hypoxemic despite aggressive recruitment maneuvers and high PEEP. Because no single metric captures the entire complexity of the syndrome, researchers use latent class analysis to identify unobserved patient groups by synthesizing imaging, biological, and clinical data. These CT images represent two distinct phenotypes identified by latent class analysis. Phenotype 1 features gravity-dependent consolidation and steep apical basal gradients, while phenotype 2 is defined by diffuse ground glass opacities and submantellar to hilar gradients. These distinct structural profiles align precisely with established hyperinflammatory and hypoinflammatory biological subphenotypes, connecting physical tissue damage to systemic immune responses. Deep learning models are currently being trained to automate the segmentation of these specific patterns from raw CT data, removing subjective bias and enabling rapid subphenotyping directly at the bedside. Integrating voxel-level imaging data into clinical models represents the current objective for ARDS precision medicine. Transitioning from standard bedside metrics to functional CT equips clinicians to treat the specific mechanical and vascular reality of an individual patient's lungs. Precision mechanical ventilation requires abandoning the concept of the lung as a single, uniform compartment. It must be treated as a highly complex, dynamic map of regional recruitability and perfusion. By characterizing these imaging-based subphenotypes, intensive care can move beyond broad strategies that historically failed and deliver targeted, life-saving support.